We're in November. It's 1/11/22. That's the date. C.T. Muga has the day's proverb before we venture into the next conversation, which is about medical research in the country.
Yes. The onion shared with a friend tastes like roast lamb.
The onion shared with a friend tastes like roast lamb.
Yes. Remember, this is
Kachumbari.
Usioila. This isn't a vegan-friendly proverb. Neither is it a vegetarian-friendly proverb. Because if it were, it would have been an onion shared with a friend tastes like roast onion. Now you see, you remain faithful. But the moment you bring in
Meat.
that story is south.
It goes contrary to everything else.
Natari, what do you think of this proverb? Comes from Egypt, though.
Okay. It's an interesting one. I think it means a problem shared with a friend is easier.
Wow. Yes. A problem shared with a friend is easier, is lighter, right?
You know, that's the positive aspect. A problem shared with a friend is fodder for social media.
Na watu wanaumia huku nje.
Ile shida. Tusipoambia jina la shida moja.
If you just listen to people's problems out there,
My friend. In fact, you realize you don't have problems.
You thank God for your situation. You're okay. Dr. Lynda Isaaka is a medical researcher with the KEMRI Wellcome Trust Research Program. Good morning and welcome to Kenya's biggest conversation.
Good morning, and thank you for having me today.
It's we now know KEMRI Wellcome Trust very well. We have visited the facility in Kilifi. We have seen some of the work that's being done by researchers there. We have seen also some of the work that's being done by researchers elsewhere. You're not based in Kilifi?
No, I'm based in the Nairobi office.
Okay, so there's a Nairobi office?
There's a Nairobi office, yeah.
All right,
Yeah.
of the KEMRI Wellcome
Trust.
Trust
Yes.
program.
Yeah.
You have been dealing with research on pneumonia, especially pneumonia among children.
Yes.
What is pneumonia among children? First of all, what's pneumonia? You know, some people just don't understand when you talk about pneumonia, what exactly it is.
Okay, so I'll just give a brief overview of what it is. So pneumonia is an infection that usually infects the lungs, and the lungs usually have what we call these tiny little air sacs called alveoli. So when you breathe in, the alveoli are usually filled with air. So when a person has pneumonia, what happens is that those little air sacs become filled with pus and with fluid. So it makes it difficult for someone to breathe and for someone to actually have enough oxygen intake. So pneumonia essentially is just an infection of those air sacs in the lung. So it can be caused by different types of organisms or germs, such as bacteria, viruses, and fungi. And usually how we get or how someone contracts pneumonia is that these germs or these microorganisms are usually found in the air. So our immune system, how it's built to protect you against those microorganisms. But if for one reason or another, your immune system is overwhelmed, you get an infection. So when those microorganisms or those germs are usually found in your nose and in your mouth. So when you sneeze or when you cough, tiny little droplets are released, and then those droplets usually contain those germs.
Okay.
So if you stand next to someone who has sneezed or coughed and you inhale those droplets, the organisms or the germs enter your system and then they go cause disease. Or if they sneeze or cough onto a surface like this and then you come and touch and then you come and touch yourself, you get the infection also.
These microorganisms that bring about these clear problems, where do they come from?
It's an interesting question. Some of them predate us, humans. They've always been there, I guess.
And they're prehistoric.
Prehistoric.
Those are really old things. Yes.
Yeah. So, and as time goes on, newer and newer variants or newer and newer strains are found.
There are two words that I have often found should we say, interesting, because I hear them, I've heard them being put in use. I think I understand one, but then when they use together, I don't know what means which.
Okay.
Pneumococcal, pneumonia. Pneumonia, pneumococcal.
Okay.
How do you differentiate this?
Okay. Pneumonia is the actual disease. Pneumococcal, there's a type of bacteria called pneumococcus that's usually associated with the pneumonia. So if you hear the word pneumococcal, it most likely refers to that organism. But pneumonia is just the term.
It's a general term for the
exactly,
disease.
yeah.
So there are other different microorganisms that cause pneumonia.
Yes.
Not just pneumococcal.
Not just pneumococcal.
Okay.
For example, COVID. Do you remember
Yes.
SARS-CoV-2? Yes.
So COVID is a pneumonia. Walk right into that one.
No, it would not be correct to say that. The virus that causes COVID, SARS-CoV-2, can cause pneumonia.
Okay.
But not everyone, it's important to note, not everyone who has a COVID infection will get COVID pneumonia. It's a very small proportion.
So not all respiratory diseases are pneumonia.
No.
Or lead to pneumonia.
Not all of them are pneumonia because, something like a flu or a cold is a respiratory illness, an upper respiratory tract infection. Yeah. So not all respiratory illnesses are pneumonia.
Okay. So there's the other thing that people really, really get scared about pneumonia. That you hear somebody who was okay, suddenly fell ill, they went to hospital and they died. What is it? Actually, they had pneumonia. This person wasn't coughing. This person was fine. This person just went to hospital just the other day just because they got up and they had a fever and something and then just went south. So how do you explain that? I mean, if you're talking about the inability to breathe, the infection into the lungs, and there was no issue at all, no wheezing, no coughing, and then suddenly you've gotten to pneumonia at that stage, what leads to this?
Okay, I'll answer your question in two parts. Usually there are some characteristics that a person might have that put them at greater risk of, one, getting pneumonia, and two, getting the severe form of pneumonia that can result in adverse complications. So some of these risk factors are age, especially extremes of age. So you have adults age 65 and above, they are at very high risk of getting pneumonia and severe pneumonia. Then, of course, we have very young children aged 2 years and below. Those ones also have a very high risk of getting pneumonia and actually getting the severe form of pneumonia. So, and the reason why these two age groups are more susceptible is because the older you get, the more your immune system is, declining.
I need to observe this. When the good doctor keeps saying the older, she's just looking at
Oh my goodness.
No, carry on. I get the message.
No.
I'm at risk. I've understood it.
You get it.
I know I've got it. Please go on.
Okay. And in the young children, the immune system is not as strong, for example, as all of us.
In the room.
In the room. Yeah, so pneumonia can be life-threatening in these two extremes of age. And of course, there are some conditions that someone might have that predispose them to getting serious infection. So things or conditions that reduce your immunity, like cancer or HIV, chronic illnesses like diabetes and chronic lung illnesses. And then, of course, there are other lifestyle choices that people make that can put them at greater risk. Things like smoking, things like drinking, things like drug use. So you'll find in a patient like the one you've just mentioned, when the doctor takes a history, and a history basically involves the doctor asking questions to find out, the origin of the symptoms and the overall health of the patient. There'll be pointers or there'll be clues that would explain why this specific person ended up getting the disease and possibly died.
One hears of research that is conducted into understanding this disease and understanding how best it can be combated, either by preventing it or by, when somebody has already contracted it, by providing a cure. Now, of the researches that you conduct, what is your focus? Is it in children? No, let me start. Is it in the two diverse groups, extreme groups, where it's most likely to occur? Is it in areas where one finds commonality of the disease? And of course, when you answer that question, I'm going to ask you, and what have you found?
Okay, so we focus mostly on childhood pneumonia in children, more specifically children aged less than 5 years. So what we are currently doing, we have a study that is running, a clinical trial in 13 hospitals across the country, and we're trying to find out the most effective treatments.
Could I just pause you for a single second?
Sure.
Just mention the hospitals and where they are.
The hospital, okay.
Yes, the 13.
Okay.
Yes.
So we have Mama Lucy Kibaki Hospital, we have Naivasha County Referral Hospital, Embu Level 5 Hospital, Kiambu County Referral Hospital, Machakos Level 5 Hospital, Thika Level 5 Hospital, Bungoma County Referral Hospital, Busia County Referral Hospital, Kitale, Kakamega County Referral Hospital. Then we have Kisumu County Referral Hospital, Nakuru Level 6, and finally we are expanding into Jaramogi Oginga Odinga Teaching and Referral Hospital.
Okay.
So, yeah.
I've listened. Did you hear any hospital in Northeastern Province?
No.
Okay. What I'm actually asking is,
I haven't heard even a hospital in the coast.
yes, I'll go to the coast next. So there has to be a criteria. Was this random or was it purposive?
The selection of the
Yes.
hospitals. So there's what we call the Clinical Information Network, which is a partnership between the Ministry of Health, county governments, and KEMRI Wellcome Trust. And within this network, we have a number of hospitals, I think slightly over 20 hospitals. So the hospitals that we are conducting the study are found within that network. We found it was easier to get or to start the research in those hospitals. Yeah. Of course, the network
But what's the membership requirement for this network? How do you join?
Well, it's not like an exclusive club like Windsor. Yeah, but I'm sure there's a colleague of mine who will come and explain more how the hospitals
How this
usually-
network works.
how this network works,
And
and
how
how
it's formed.
hospitals joined.
Then
Yes.
please carry on.
Okay. So where was I? Oh yeah. So we are currently carrying out a study in these hospitals to try and test and find out which antibiotics are most effective for treating these children with severe pneumonia. You find that I don't know if you've seen this or if you've read this. Pneumonia is actually the number one cause of death, infectious related deaths in children. It accounts for about 14% of all deaths in children aged below 5. So every year, about 800,000 children die. That translates to 100 children per hour.
Wow.
So by the time we're done with this, 100 children would have died.
In Kenya alone?
Not in worldwide.
Worldwide,
Yeah.
okay.
Yeah. So we're trying to find out which treatments would be effective to try and reduce that rate of death or that mortality.
Now, when you talk about this is a clinical trial.
Yes.
Okay. Are you able to talk about the drugs that you're testing?
Sure.
Because if it's a clinical trial, there must be drugs
Yes.
that have been used before. And we would like to know, what is it about these drugs that you want to find that previously was not known? Yes.
Okay. So the drugs that we are testing are what we call the current standard of care. So there are usually guidelines that are released that guide clinicians and healthcare workers on which treatments to use. For pneumonia right now, the current standard of care is an antibiotic known as benzyl penicillin plus gentamicin. So in our clinical trial, we are going to compare benzyl penicillin plus gentamicin with another commonly used injectable antibiotic called ceftriaxone and another one called amoxicillin clavulanic acid, or amoxiclav in short. So you see, these guidelines have been in place for a very long time, for almost 30 years. And you know, how pneumonia has advanced. We've had introduction of vaccines that have tackled the two main bacteria that cause bacterial pneumonia in children, and the introduction of these vaccines has resulted in, a significant decrease in the pneumonia that's attributed to these two organisms. But even despite that, the mortality still remains high. There are so many children dying. So we have to ask ourselves, what is causing these children to die? We've given them the vaccine that protects them against the two most common organisms that were causing pneumonia. They're still dying. So is it the treatment that we're giving them? Yeah. Is it, do we have other causes of this pneumonia that we don't know? And our study actually aims to find out that.
Are you looking at the dosage as well?
Sorry?
Are you looking at the dosage?
No, we're maintaining the dosages as they currently are. Yeah, what we're just looking at is the effectiveness of the drug. Yeah. And one important thing to note is that this is the first study of its kind that is comparing different injectable antibiotic treatments for these children with severe pneumonia that we know of in the entire world. So, yeah.
It's the first of its kind. There have been other studies.
There have been other studies, but
not
none as large. Yes, not none that are comparing the injectable antibiotics like this, and none as large as this.
There's a vaccine.
There's a vaccine, yes.
It's a pneumococcal vaccine.
Yes.
Are you then not saying that this vaccine isn't quite doing what it's supposed to do?
No, the vaccine has done what it's supposed to do.
Then why is it that these cases don't seem to drop? Is it that the vaccine isn't widely enough received or widely enough applied, widely enough used? What is it? Because if a vaccine exists
and it's effective,
then this story ought to have a different twist to it than the current one.
Okay. Remember, we said that pneumonia can be caused by bacteria and viruses. So the vaccines that were introduced, actually two, and they protect against the two main causes of bacterial pneumonia in children. What was determined to be the two main causes of bacterial pneumonia in children? And allow me to be a bit technical. The two bacteria were Streptococcus pneumonia and another one called Haemophilus influenzae. So when they were introduced, there was actually a study that was done that compared, the rates of pneumonia just before the vaccine was introduced and just after it was introduced. And we saw that the pneumonia attributed to the strains that are covered by the vaccine of these two bacteria reduced. So that tells us that these pneumonias that we're seeing, it's likely that they are caused by something else. Another type of organism, most likely viral in origin. Yes, not the bacteria as we previously
thought. So not
thought.
bacterial, but viral.
Likely viral, exactly. So
What would you need to establish this for a fact?
Great. That's a very good question. So what we do is we test. We do what we call, or in our study, we'll be doing what we call a nasopharyngeal swab. Remember, during COVID,
Just explain
that thing
that was entering your nose.
That very invasive thing that goes through your nose up to your brain.
Makes you tear.
Okay, not really up to your brain, but it was.
People are seeing dim after that things.
Please go on.
Yeah, so we'll be taking a nasopharyngeal swab and now processing it in the lab to try and look now for which organisms that are causing the pneumonia in these children.
Research by its nature seeks to respond to questions that have previously not been well answered. Okay? Now, what is it that this study in all these sites, what is it that you're hoping to determine? What question are you seeking to answer?
We are seeking to find out, one, which antibiotic is going to be effective at treating these children who are hospitalized with severe pneumonia. So we'll compare the three of them to find out which one is the most effective. Then over and above that, we also want to find out, children who are very sick have what we call increased caloric demand, and we have to...
And what is that, increased caloric demand?
They require more energy than usual. And, we get our
So they
energy
require more
from...
calories
Exactly.
to be able to have the energy to do the things they need to do.
Exactly.
Okay.
And also to fight the disease,
Yes.
in quotes. So usually how we supplement this energy is we either feed them through a tube that is put through the nose, or we give them fluids through a vein. So we'll also be comparing between those two, which one is more effective in providing supportive care, nutritional supportive care to these children. Then another one is to now find out what exactly is causing this pneumonia, which viruses. We know that it's likely to be a virus or viral in origin. So which specific viruses will be causing that?
Well, I think after we take a break, you'll tell us why we should care.
Okay.
Okay?
Yeah.
You people are doing your thing, nasopharyngeal, whatever, looking at injectables and what, and looking at microorganisms. And what did you call them? What did you call it?
The pneumococcal and all that.
Those ones.
Yeah.
All those things that you're doing. Why should we care? Right?
Yeah.
Dr. Lynda Isaaka is a medical researcher at the Kenya Medical Research Institute, KEMRI Wellcome Trust Research Program. She is based here in Nairobi, and they're doing a lot of work on researching on childhood pneumonia. In fact, they're conducting a first of its kind research in the world on causes of this severe pneumonia in children under 5. And you're saying it's first of its kind in the way you're doing it.
In the interventions we are.
In the interventions that you are
comparing. Yeah.
First of its kind. These things happen in Kenya, first of their kind.
Only in Kenya.
Yeah. Dr. Lynda Isaaka, first of her name.
Made in Kenya.
This is the Situation Room, the only way to start your day.
Eric Latif, C.T. Muga, and Dr. Lynda Isaaka, a researcher at KEMRI Wellcome Trust, who's involved in some research on childhood pneumonia in Kenya and beyond. So, Dr. This thing that you're doing, why is it important?
Well, like we saw earlier, so many children are dying from pneumonia, and most of these deaths are easily preventable. And there are things that we can do before it reaches the point where they're hospitalized, and I'll cover some of those strategies that we employ later. But we want as much as possible to reduce the number of deaths that are caused by pneumonia in these children. 100 children an hour, that's a lot of kids dying.
That's a very high number.
Yeah.
I have to ask this question. Since these deaths, these mortalities are found in children, do you work with the Kenya Pediatrics Association or any organization that is involved with pediatrics in the country?
Yes, we partner a lot with the Kenya Pediatric Association and also through their research arm, Capricorn. We also work very closely with county governments and more specifically the pediatric departments in the county hospital. And of course with the Ministry of Health, more specifically the Division of, I think it's Child Health, and the name has escaped me, but yes, we work very closely.
When you say work closely, what does that entail exactly?
We partner with them sometimes to carry out activities such as training of hospital staff, where hospital staff need to be trained, especially on things such as what we call ETAT. And ETAT is a course that is usually provided to healthcare workers to train them to be able to manage very common pediatric emergencies. We also partner with them to sometimes, support the hospital where we can with providing equipment such as pulse oximeters.
What meters again?
Pulse oximeters.
And those are?
Okay, so a pulse oximeter basically is a type of machine that detects the level of oxygen in your blood. So I'm sure most of us in the last year or so have either gone to hospital or taken someone to hospital. Usually before you see the doctor, there's a nurse who takes your vital signs. So she'll put something on your arm to take your pressure, and then something on your finger, a kind of probe on your finger. So that probe that she puts on the finger has a sensor.
It's like a peg.
Like a peg, exactly. Yeah. So the peg that's put on your finger has a sensor that detects the amount of oxygen you have in your blood. So that machine is called now the.
Why is it important to know the amount of oxygen in one's blood?
Because if it's, there's a certain level beyond which it should not go down.
Why?
Because if you don't have enough oxygen in your body, your cells will not function. To put it very simply, will not function the way they're supposed to. Yeah.
And when they don't function, what happens?
Well, you can have...
that is, aside from dying, what happens in an intervening moment before you get...
Before you
Does it
die.
head towards death?
Yes.
Yeah, so now... your cells, they start slowing down, your organs start slowing down, they don't work the way they're supposed to, which predisposes you to getting even more ill. And then at the very extreme end, if it's very severe and very prolonged, you die. Yeah. So oxygen is very critical to how our cells function and work.
Something that I've always found particularly interesting when I talk to people who are in the world of research, people who work in research get very involved in what they do. So you get the impression that they have to have an interest in what they do. That's why they do it. But how much time is taken to actually explain what you do to the people who eventually consume the outcome? For instance, now you're working in, is it 13 hospitals? Okay. The other departments within the hospitals who are not involved in this research, how much do they know about your research? You've told us that you build capacity of the people who work in these institutions, and that is an excellent thing. And even when you do have your findings, how do you know that beyond publishing it and beyond talking about it, that people actually understand what it is that you found and what you did? What do you do to ensure that this happens?
Okay, that's a good question. So what we do in our study specifically, we usually have what we call regular continuous medical education sessions, or CMEs, in the hospitals. So where we invite not only the departments that are directly involved with our study, but any other person who's interested, and we give them updates on what we're doing on pneumonia, etc. Another avenue that we use, every year we usually celebrate World Pneumonia Day, and this year it's on 12th November, as with every other year. That's next Saturday. So that's another excellent opportunity that we usually use to educate, to inform, and to spread the word basically about what we're doing. Yeah.
How about the community? Like, I'm sure there's a lot of information that the community would like to know on A, understanding pneumonia, B, understanding how to avoid getting infected with pneumonia, how to avoid passing on pneumonia to other people. Do you conduct such public awareness?
Engagements. Okay, well, this is an example, but there is a department, at least within our organization, that deals specifically with that. And I think, if I'm not wrong, you might have spoken to them about how they go about doing that. So they'd be in a better position to explain the exact nature in which. But yeah, we do have that department that engages with the community.
Your research involves young children. Young children is, when a child is sick, there's a whole emotional roller coaster with the caregiver, the parent, the guardian.
Yeah.
And now they are seeing these doctors doing all these things that they're doing. How do you explain to the parents exactly the nature of the work that you're doing? That in addition to seeking to cure your child, we are also conducting research on your child. And they get to understand immediately and they say, it's fine, go ahead.
Okay. So usually what happens before we enroll a child into our study, the first thing we do is we screen. And screening basically involves using specific criteria to determine whether or not a child would be eligible to be in our study. So once we see that...
So I thought criteria number one is one.
Is?
This child has pneumonia.
Yes, that's one of the criteria. And then
there's more.
There's more, yes.
Like...
Okay, so the criteria are usually divided into two types. We have what we call inclusion criteria and what we call exclusion criteria. So inclusion criteria are the characteristics that a potential child who will be enrolled into the study must have. So for us, the child must be aged 2 to 59 months. Okay. The child must have severe pneumonia. and we must have gotten consent from their parent for the child to participate in the study. Then exclusion criteria are those characteristics that would exclude or would, what's the word? Disqualify, thank you, a child from being part of the study. So in an ideal scenario, we want any child who is part of our study to have all the inclusion criteria, but none of the exclusion criteria. So once we find that a child is eligible, the next thing that we do is we sit down with the parent to get what we call informed consent. And that is usually a process. Yeah, you just don't go to the parent and you're like, your child is, eligible for this study.
Eligible.
Exactly. Sign here. Exactly. We have to take them through a discussion on the study. Why are we doing this study? Who is doing the study? Where is the study being done? For how long? What are the risks? Yeah. What are the benefits? Yeah, if any. Are there any alternative treatments? Of course, some of them usually have concerns about the data that we collect. How would we keep it confidential? Yeah. Who is running the study? And by who, we also have to include the name of the
specific individuals involved.
Exactly, the specific individuals involved. Yeah. And then that discussion usually gives them a chance to ask any questions that they have, because we don't want a scenario in which the parent feels like they're forced or they've been coerced, or they feel like they have to be part of the study, or else their child will not get. Yeah. So we take them through that entire discussion and answer any questions that they might have. And if they're okay, they sign and the child is enrolled.
By percentage, how many rejections do you get?
So we've been very lucky so far. Our rejection rate has been very low. Very low. I think maybe about less than 10%. Yeah.
Is it not a point of concern? At this point when my child has severe pneumonia, they're in HDU, right? I mean, they're ill. And this is a child who is just a few months old. Of course, the thing I want is for my child to live. Now, when you're bringing me all this information, or knowing there's a study that we are conducting, I don't know, we are doing what, we're checking what works and what doesn't work, and these are the people who are involved. The only thing I'm hearing is my child is sick. And the longer this person is talking to me, the longer they are taking from attending to my child. Now, how do you balance that? The fact that this parent their primary concern is the well-being of the baby. These are the details. Whether they're actually getting in or not is something else.
That's a very good question. So in a situation where the child is critically ill, like very ill, what we do is that we don't go through that entire process. We get what is called assent. So we tell the mother, we just give her a very brief summary. We tell her, there's this study, this is what we intend to do, this is why we're doing it. If you're okay with your child being part of the study, just let us know, and then we'll come back later and have a more detailed discussion. So in such critically ill children, you're right, the parent is genuinely concerned about the child, and they're like, why is this person talking to me? They're wasting time. Yeah, so we get that assent, and then later we come back and have a more detailed discussion.
So essentially you enroll participants who have actually come to seek care.
Yes.
Now, when they have sought the care, they have received it, and they've benefited from it, what do you do to follow them up to ensure that the care that was given has the long-lasting effect that was desired?
Okay. It's a good question. So when we enroll participants into our study, we follow them up for the period of time they're in hospital, then until they're discharged, actually, Then 30 days later, we do a follow-up call just to try and find out how is the child doing. Were there any serious issues that occurred? Were they readmitted? Do they still have symptoms? Are they fully okay? So over and above just following them up while they're in hospital, we do conduct a follow-up visit or a follow-up call 30 days later.
Do you specifically or deliberately ensure that you actually know where they come from so that you can follow them physically?
Yes. So at the point of enrollment, we require them, or rather, we ask them to give us 2 phone numbers because we do our follow-ups via telephone. So 2 phone numbers for which they are sure they'll be reachable. So on the day of the follow-up, we call the numbers, and we conduct the follow-up.
They don't fill these laborious forms where you sort of like give you details. Now, the village I stay in, there's a big baobab tree next to a clinic, and the name of the clinic is Get Well Quickly Clinic.
When you get there, ask for Mama so and so.
So, yes, okay. And there are 2 clinics, yes, with the same name, but the one where I am known is the one with the yellow door.
Okay. Yeah. Uh-huh.
Do you go into such details?
No, I think the phone number is enough to facilitate that follow-up. I think majority, is it more than 80%? I could be wrong, of Kenyans have access to a mobile phone. Yeah, so it's very easy to conduct this follow-up visits or calls by phone.
I'll tell you why I'm asking the question. The patients that you deal with, or the patients that were in the study, if I'm wrong, please correct me. I get the impression that people who come to hospital fairly critically ill. They're not well. Now, it means they have been unwell for some time, but the parents have thought the kids are okay. Now, a telephone call doesn't quite tell you how the person is doing because it's being reported.
Yeah.
Now, the physical follow-up will now give you, the healthcare provider, a clear indication, because the telephone follow-up is good.
Yeah.
You're communicating, but to actually see for yourself and say, is this child really doing well? Because sometimes the parents or the guardians may think the child is doing okay, and whereas a trained eye will know this child is not doing as well as they could. It is for that reason that I asked whether you actually make a physical follow-up.
So for us, we're not doing the physical follow-up. The only time we do a physical follow-up is if they're unable to provide the 2 phone numbers. Yeah, we rely primarily on the telephone follow-up.
Actually, the age of communication has made very many things possible.
Completely. Actually, when you conduct this research and, you got consent from a parent and you started your trials on a child, and in the event a child dies, as it's likely to happen, what is the reaction from the parent? Do they look at you and blame your research and feel that, it's because of the thing that you are doing that, you actually reduce the chances of my child living?
Okay, that's a very good question. It varies from parent to parent, but we've not had, nothing stands out where a parent was like, you guys caused the death of my child. These children are usually so ill, so severely ill, that sometimes you can actually see that maybe this child may or may not make it, and they're usually prepared for that eventuality by the staff in the hospital or by the doctors who are attending to them. So very rarely do we have a situation where a caregiver comes and tells you it's you who caused the death of the child. So
the other question that you said, big concern for people, is confidentiality and the repository of the data. So who keeps the data?
So we keep the data.
Who's we?
The research team.
Okay.
We usually keep the data. We archive it for a specific period of time, and then after that, once that time has expired, we may dispose of the data. Access to the data is very limited. It's only who needs to see it. Yeah, and in the event that someone needs to see it, they need to seek permission or consent before. So we maintain confidentiality very strictly.
And all this is covered in the protocol?
Yes, it's covered
in detail.
In detail.
I am interested in finding out what it is that you do with the participant and their families with regards to some of the fundamental pillars of human protection in research. The beneficence part of it. Child has left. They've received care. What other benefits do they derive from being participants in this study?
That's a very good question. the most direct and the biggest benefit they have is that they get
well.
treatment.
Yes.
Yeah, and they get well. Yes. Others, well, there's a knowledge that, you contributed to this study that is going to result in a change of guidelines. But the biggest direct benefit to them is they get the treatment. That's the biggest in our study.
See, the reason why I ask, when we think of the understanding of what research processes are and how it is communities need to interact with this information and how they need to understand it, the literacy level of understanding, adhering to these principles enable communities to understand better. You see, when we talk about benefits, because the larger picture is that many people will benefit from this research, that's in the future. Most people live in the present today. Tomorrow is often very far away.
Guaranteed, yeah.
Okay. Now, when someone is well, yes, they will see the benefit, and the community will see this person is better, and they will understand. Let me ask the question I want to ask.
Yeah.
That is just the background. When you look to employing people who do your community work, do you look for individuals who come from the communities within the places you're working in to be part and parcel of your research process?
Yes, we usually do that. And
No, go ahead.
sorry.
Yes.
Yeah, we usually do that. We work as much as possible with the people around there, because it doesn't make sense to bring an expert into the places where we work because of issues around acceptability. Do they even understand the community? Do they understand the population around that area? So yeah, we try as much as possible to work with the people within the areas where we're doing our research. I don't know if I've answered your question.
Yes, you have. But that was question 1A. Now, question 1B, the actual process of collecting the information of the data, yes, it's within a hospital setting. But when you talk about the 13 sites where you conducted this particular study, the question that has been swirling in my mind is this. Have you interacted with any information that gives you an indication of places where pneumonia is more prevalent than others? And in the areas that they're more prevalent, is there information as of now as to why it is you find prevalence? I'm thinking of this because I look at a disease like, say, malaria. There's an understanding of why you find malaria in certain places more than others. What about pneumonia?
Well, remember the information network that I talked about earlier, the clinical information network. So they've been doing work around that. And I think they also looked at what you've just asked, where pneumonia is more prevalent or where it's found more. And some of the factors that were associated with pneumonia being more present in some of these hospitals compared to others is the presence of children with conditions that predispose them to severe pneumonia, such as severe acute malnutrition. There are some areas in the country where the proportion of children with malnutrition is higher than other areas of the country. So we tend to find that the pneumonia cases tend to be more in those areas, and they tend to be more severe in those specific areas. Yeah, but if you want like a more detailed or in-depth look on that, I'm sure there's a colleague of mine who will be joining us or coming to discuss more about the work that the CIN does.
So at the end of all this research, say you have established this is what we are seeing. This is the combination of drugs that works best, or actually we have a new strain of pneumonia that's actually caused by this particular virus. What happens with that information? Who do you give that information to?
Okay, so that's a good question. So once we get the results, of course, we'll share the results, and these results will actually be adopted to form policy surrounding the guidelines for the treatment of these these children with severe pneumonia. So, of course, we'll share them locally with our own experts and also internationally. whatever findings that are found or recommendations that are made based on our studies, they'll have to be reviewed, people agree, they have consensus, and then we have new guidelines put in place.
Right.
Over and above that, any information, of course, we get from our study can also, more so surrounding the etiology or the causes of this pneumonia. Like you said, maybe there's a new strain or there's a new virus that's causing. The information that we get will also be able to provide evidence that we will be able to, improve some of the strategies we already have in tackling pneumonia. So, yeah, hope the question has been answered.
So if for example, you discover that there's actually a pneumonia that's caused by a virus, what happens next?
Well, what happens next is, okay, so it's caused by virus X. So how can we, we look at what we already know when it comes to tackling pneumonia. How can we adapt this new information to come up with optimal strategies that will help fight this pneumonia in these children? We can also look at, okay, we have seen that it's this virus that causes this. What research can we do into determining new treatments? What research can we do to determine new vaccines against this? Yeah, so it feeds into additional research and additional work that can be done to try and,
and if, as you find out all these things, the medicine that's being used, the treatment is not going to be effective because it's not dealing with the virus. So what happens in the intervening period?
Well,
researchers have found out that, there's pneumonia caused by a virus.
Yeah.
What you're giving people is antibiotics.
So, of course, now we'd have to, like I said, change, inform
Change
people.
course.
Actually, what researchers do, they conduct more research.
Yes.
Don't do it.
Yes.
Okay. Dr. Ariwi, thank you very much for joining us today.
Thank you.
Asante sana. Dr. Lynda Isaaka is a medical researcher with KEMRI Wellcome Trust Research Program, conducting some research on childhood pneumonia in Kenya and beyond, looking at what has been known so far and trying to find out what the unknowns are. The known unknowns and the unknown unknowns as well. Dr. Ari, thank you very much for joining us.
Thank you for having me.
Yeah.